just finishing up chapter 12, which was on the cardiovascular system. And it was a huge chapter with tons of disorders, all with similar symptoms. The chapter 13 is on the respiratory system, and it is the same. It's a huge chapter of an important system with many disorders, all with similar symptoms. So we're going to start at the beginning, and we're going to review respiratory function, which hopefully you had some of in anatomy and physiology, and we'll go through. So for this first lecture, the learning objective is I want you to be familiar with the common terminology of the respiratory system. So we're going to talk about some structures and function and terminology and some diagnostic tests for the respiratory system that are common across the board with different respiratory disorders. So it'll probably be divided into 2 lectures. You know how I do it. So the respiratory system is pretty important. It's the only way we can get oxygen into our system from the air into our blood. And oxygen is necessary for everything, for cellular metabolism. If we don't have oxygen, we're anaerobes. We need oxygen. So we need to get it in. Plus, we need to remove carbon dioxide, which is a byproduct of cellular metabolism, from the blood. So carbon dioxide is our byproduct, our waste product. When you burn hydrocarbons in oxygen, you get water and carbon dioxide. That's how it works. Chemistry, right? It's beauty. It's beauty. I don't know what's more exciting than that little equation right there. Of course, I'm a chemistry geek, so you gotta take that into account. So in order to remove the carbon dioxide, you could say, oh, well, let's just let it float around and work in the system. But remember, carbon dioxide is held as bicarbonate ion as part of the buffer system for the acid-base balance. So if you don't get rid of carbon dioxide, you will be in respiratory acidosis. Okay, we don't want that. We want to get rid of it. We want to keep our acid-base balance in the range where we're not going to die. So we can maintain homeostasis, always a good thing. So if your respiratory system is depressed for whatever reason, like opioid overdose, metabolic acidosis is what gets you because your respiratory system is not getting rid of carbon dioxide. So on the list that we're making of things that eventually kill you, you could put respiratory acidosis right up there. Or it could kill you. And not say it's gonna, but it could kill you. There are 2 main areas, anatomical areas of the respiratory system, the upper respiratory tract and the lower respiratory tract. So the upper respiratory tract has resident flora. We have our normal flora that live there, but the lower respiratory tract is supposed to be sterile. No normal flora down there. If you get them down there, that's a problem. That could be pneumonia, which is another thing on the list of things that might be your last illness. So keeping the lower respiratory tract sterile is pretty important. So, we got to do that. In the upper respiratory tract includes the nasal cavity, which its job is to warm and moisten incoming air. If you're in a super dry environment, you're going to breathe out moisture and you're not going to be taking in any moisture. And so that can have an effect on you. And the nasal cavity also traps foreign material. It's part of the mucosal system, so it has the mucosal coating, and foreign material is trapped by mucus secretions in the nasal cavity. The nasopharynx are the pharyngeal tonsils in the posterior wall of the pharynx, and pharyngeal tonsils are part of our immune system. So they have white blood cells and other things that you find in the lymph nodes. So they're part of our immune system. They're kind of our first line of defense in catching things. The palatine tonsils are lymphoid tissue that are in the posterior portion of the oral cavity. And so the differentiation between pharyngeal and palatine is their location. They both do similar things for the immune system. In the upper respiratory tract, we also have the oropharynx, which is the common passage for air and food. So you might say, well, that's kind of problem, like air and food. You can't mix them. You can't inhale food into your lungs. That's a bad idea. And well, you could get air into your digestive system, but that could cause problems as well. So there are structures that their job is to keep food out of your lower respiratory system and to make the food go down the right direction. So the epiglottis is what protects the opening into the larynx, and we do have there's a coordination of swallowing and the epiglottis covering the glottis to prevent aspirating food and liquids as we eat and drink. So our upper respiratory tract is not only the entryway for air, but it's the entryway for food, which we also need to take in on a regular basis. Maybe not as regular as air. That was like the little rule of thumb, like you can live weeks without food, days without water, but only minutes without air. So air is probably the most important thing, but food's important too. Our larynx includes two pairs of vocal cords, and air going across that makes it so we can make sounds and talk and communicate. Isn't that amazing? I think that is like one of the best parts about being a human being. You probably know that about me since you know how much I talk. But there you go, there's our larynx. So not only can we talk and communicate, but we can sing and um, express ourselves through our voice, and that's amazing, I think. And I work with some speech therapists, so I have super high estimation of how important that is. And I also work with a lot of patients who have voice problems because I work with the Parkinson's population, and it affects the voice muscles as well as it affects other muscles. And so voice problems are common with Parkinson's, and luckily there is treatment for that. Go to your LSVT certified speech therapist and get some loud training and retrain your vocal cords, reset your nervous system. So the trachea is lined by pseudostratified ciliated epithelium and C-shaped rings of cartilage to keep that airway open. That's the job. So if they're going to have to bypass, if you have something like mouth trauma and air can't get in through there, they might have to bypass by going through the trachea. Tracheotomy is where you make a hole from the outside to the inside, and it goes through the trachea to open an airway. So if somebody has an endotracheal tube, it goes in through the mouth and down the trachea. If they have a tracheotomy, it goes from the throat through the front of the trachea. And you can feel, if you relax your neck, you can feel the cartilage rings on your trachea. It's kind of neat. Okay, so once you get past the trachea, then you're into the lower respiratory tract. And here's the part where you got to keep it sterile if you don't want to get pneumonia. The trachea branches into left and right primary bronchi. Then those branch into secondary bronchi, those branch into bronchioles, their terminal bronchioles, respiratory bronchioles, alveolar ducts, and finally the alveoli. And so it's very similar, you might find, to the circulatory system where arteries branch into arterioles, branch into, and then eventually you're down to capillaries. The main difference being that the alveoli, so the alveoli are sort of like the capillaries of the respiratory system, if you want to follow that analogy all the way to its little end. And the alveoli are one cell thick, just like capillaries are one cell thick. And the pulmonary capillaries meet the oxygen in the alveoli. So that's our site of oxygen exchange. They're lined by simple squamous epithelium, and they have this chemical surfactant in them to reduce surface tension. So if your alveoli don't have sufficient surfactant, the insides are gonna stick together, and it's gonna be like those produce bags at the grocery store where you can't get them apart and you can't get air into them. And that's called atelectasis, when your alveoli can't inflate, and that's a problem, and we'll talk about that later. So the surfactant reduces surface tension to maintain inflation, and our alveoli are the end point for inspired air. It's the site of gas exchange. So really important, right? Super important area. So the surfactant in our lungs, when we're babies, Oh, not babies, sorry, pre-babies, when we're fetuses still inside our mother's circulatory system is providing oxygen to us. And so our pulmonary system isn't quite working until we are born into the air. And then guess what, guys? You're online. You gotta you gotta breathe now. Get us some oxygen. So premature babies often have not developed the surfactant in their lungs. And so if they know that a baby's going to be premature, and a lot of times these days they do know for whatever reason, difficult pregnancy, they will start to give the mother medications to increase the surfactant inside the baby's lungs. So when it's born, its alveoli will open. So that is pretty important. So it's something that we need to live, and we need to keep those alveoli open and prevent them from collapsing to maintain that inflation. So ventilation is the process of inspiration and expiration. And the airflow depends on pressure gradient. So we talked about we've talked about this with different systems, like with electrolytes and acid base and hydrostatic pressure and osmotic pressure. A lot of the movement of things in our body, whether it's ions or fluid or air, depends on gradients. So there's going to be a pressure gradient for gases. There's going to be chemical gradients, electrochemical gradients when it comes to neural activity and muscle activity. So gradients are the energy storage, the chemical and physical energy storage for our body, and that's what makes things work. So you need to have a gradient, and air always moves from high pressure to low pressure, just like fluid moves from high concentration, or less dissolved to solids to more dissolved solids. So it goes to where there's less of it, basically. So high pressure to low pressure. Atmospheric pressure is when atmospheric pressure is higher than pressure in the alveoli, air moves from the atmosphere into the lungs. When pressure in the alveoli is higher than the atmosphere, air moves from the lungs into the atmosphere. So the structure of the lungs and the muscular support for breathing actually causes those pressure changes, which that's pretty cool. So, it's amazing. I think it's amazing. So we talked about sort of the kinesiology of ventilation at the very, very end of the quarter. Hopefully you remember that in fall quarter. And so you have all those muscles helping to change the capacity of the thoracic cavity to make the pressure gradients that makes the air move in and out. So it's an amazing coordination of tasks, which I don't expect you. I'm not going to ask you about Boyle's law. But there you go. So pressure, volume, all that stuff. Gas laws. I mean, I love that stuff, but this isn't a chemistry class. We're just going to talk about it. So we talked about how the cardiac rate, the heart rate is controlled by the nervous system, the sympathetic and parasympathetic nervous system. And strangely enough, the ventilation is also controlled by the nervous system. So the primary control centers for breathing are located in, surprise, surprise, the brainstem, medulla oblongata, and the pons. So we have chemoreceptors that detect changes in carbon dioxide level, hydrogen ion level, which acid-base balance, and oxygen levels in blood or cerebrospinal fluid. And the central chemoreceptors are located in the medulla, but we also have peripheral chemoreceptors located in the carotid bodies. So those are we're going to get that signal. And then the effectors and the effector neurons in the medulla and pons are going to send out the signals to the muscles to contract and do the inspiration and expiration that we need to do. So it's controlled by the central nervous system. Unlike the heart rate, which is controlled more by the peripheral nervous system, the autonomic nervous system, even though the central nervous system has its hand in, it always does. But there is not as much effect. There's some effect from bronchial dilation and constriction from the sympathetic and parasympathetic nervous system, but there's more control from the brainstem in the respiratory system. So that's all I'm going to say about that. But it's interesting. It's fun. It's amazing. But one of the things to think about in terms of that, this is just for future thoughts. I'm planting seeds now. I don't expect the flowers to grow until later, but I'm planting seeds. If you have a brainstem injury that affects your medulla and pons, this could be a life-threatening injury because it affects vital function. Okay, that's all I'm saying about that. Think about that next quarter in neuro when you're talking about brainstem. Okay. Oh, I went backwards. So normal control of ventilation. Here's the normal cycle. You get increased partial pressure of CO2 in the blood and the central and the cerebrospinal fluid. That stimulates central chemoreceptors in the medulla, which stimulates the inspiratory muscles. It increases the inspiratory rate. It removes more CO2 from the body. So you get decreased partial pressure of CO2. That's what that PCO2 is. You get decreased chemoreceptor stimulation, slower respirations, you retain more CO2, and that causes you to increase, it causes increased partial pressure of CO2, which stimulates central receptors. You see the cycle there. So there are people who, because of disease, and we'll talk about some of the diseases a little bit later, who don't respond to the CO2 trigger to breathe, and those people live in respiratory acidosis. So those people have diseases, and we will talk about those diseases later. So what this is, we're talking about normal, we're reviewing normal, and then we'll hit abnormal a few lectures down the road. So disorders, well, here's abnormal right now, but disorders of ventilation control. If there's something wrong. So hypercapnia is increased carbon dioxide levels in the blood. So carbon dioxide easily diffuses into the cerebrospinal fluid. It lowers pH and it stimulates the respiratory center. So you get increased rate and depth of respirations, which is hyperventilation, and it causes respiratory acidosis and nervous system depression. Hypercapnia. So this is a little bit terminology. Hypoxemia. So hypo is low, oxy is oxygen, emia is blood, so low oxygen in your blood. Chemoreceptors respond, important control mechanisms. With chronic lung disease, they move into a hypoxic drive. So in normal function, we respond to increased CO2. When you don't have that, oh, I keep going backwards. When you don't have that, you have to respond to decrease in oxygen, and that's the hypoxic drive. So it's normally you respond to increased CO2. When you don't respond to increased CO2 because of hypercapnia, then you have to respond to hypoxic drive. Hypocapnia is low carbon dioxide concentration in the blood, low partial pressure of carbon dioxide. And that might be caused by hyperventilation. You expire excessive amounts of carbon dioxide, and that causes respiratory alkalosis because you get rid of your carbon dioxide and you're left with a higher pH, basically, and it's respiratory alkalosis. So you got to be, homeostasis, you got to be in the middle, not too much of anything and not too little of anything. It's crazy. So gas exchange is the flow of gases between the alveolar air and the blood. So that's important, right? Because it has to get to the blood to get out to the cells. So here comes this great little capillary with carbon dioxide, drops the carbon dioxide in the alveoli. takes up oxygen and moves along its merry little way. And then the air goes in and out through the same passage. So remember, the circulatory system is one way. It's one way closed circle system. The respiratory system is two way. So you get different things moving one direction versus the other. So gas exchange depends on the relative concentrations or partial pressures of the gases. So PO2 is partial pressure of oxygen, PCO2 is partial pressure of carbon dioxide. So each gas in a mixture moves along its partial pressure gradient, independent of the other gases. So it's not like, oh, well, there's high oxygen and low CO2, and each one is not paying attention. It's minding its own business. It's staying in its lane. Oxygen is staying in its lane. Carbon dioxide is staying in its lane. They're going to move depending on their partial pressure gradient. They don't care what the other gases are doing. Okay, hopefully that makes sense. So I mean, that can cause some different issues, but there you go. So here's our pulmonary capillaries wrapped around the little bundles of alveoli, which look like little bunches of grapes. And it's a lovely little system where the oxygen and CO2 are exchanged with the circulatory system. The cross section, you see there, it's a single cell thick, just like the capillary is a single cell thick. So the gases can easily diffuse across the cellular barrier and get into the red blood cells, which then take the oxygen off to the cells that need it, like the myocardium and the neurons in the brain. So it's a lovely system. It's wonderful when it happens properly. So the other thing that you get in the alveoli are these little macrophages, which are trying to like prevent bad things from happening. So they're like the security guard in the alveolus. That's my analogy. I'm going with it. So the factors that affect diffusion of gases, the partial pressure gradient, the thickness of the respiratory membrane. So if you get fluid accumulation in the alveoli, like you have pneumonia or you have pulmonary edema, that impairs gas exchange. The total surface area available for diffusion influences diffusion of gases. So if part of the alveolar wall is destroyed, like by contaminants or like smoking, or you used to work in an asbestos mine or something, the surface area is reduced, so you get less exchange. The ventilation perfusion ratio affects diffusion of gases. So ventilation is airflow and perfusion is blood flow. So they need to match in order to get gas exchange. So this little formula, you don't need to know that. There it is, but you don't need to know it. So if airflow and blood flow don't match, then you don't get the best gas exchange. So it's all has to be coordinated. Every time we talk about a different system, we're like, yeah, but the circulatory system, yeah, but the respiratory system, yeah, but the kidneys, and they all contribute. So super important that they all contribute. Oxygen and carbon dioxide need to be transported in different ways. Oxygen is about 1% of it is dissolved in plasma. Most of it is reversibly bound to hemoglobin in the erythrocytes. The binding and release of oxygen to hemoglobin depend on the partial pressure of oxygen, the partial pressure of CO2, temperature, like your own temperature, and your plasma pH. That's going to affect the binding and release of oxygen to hemoglobin. Carbon dioxide, it's a waste product from cellular metabolism. Remember how I talked about the beauty of oxygen, of hydrocarbons burning in oxygen and creating carbon dioxide in water. About 7% of carbon dioxide is dissolved in plasma, and about 20% of it is reversibly bound to hemoglobin. So even though carbon dioxide exists in ion form as bicarbonate ion for the buffer system, it also is reversibly bound to hemoglobin. So most of it diffuses into red blood cells. So 7% dissolved in plasma, 20% reversibly bound to hemoglobin, and most of it just diffuses into the red blood cells across the cell membrane. So carbon dioxide can just do that. Isn't that nice? So there are lots of diagnostic tests that are standard for respiratory function. Spirometry or pulmonary function test, PFT, tests pulmonary volumes and airflow times. I'm sure some of you have probably had this test. The guy in the picture is getting it done, where you breathe into, they say like breathe out as much as you can. And they test your pulmonary function. Arterial blood gases, which if you recall in the cardiovascular chapter, they were sometimes used to estimate some or to evaluate some things in the cardiovascular system. It checks your oxygen, carbon dioxide, bicarbonate, and serum pH level in your arterial blood. Oximetry, which we do every day in the lab and in the clinic, measures oxygen perfusion or O2 saturation. And we usually report it on the chart as O2 sat. And we'll say O2 sat, it's a percentage. And if they're on oxygen, you say how much oxygen they're on, like on 2 liters of oxygen, or on room air, if they're just on room air. Exercise tolerance testing, similar to treadmill stress testing for cardiovascular stuff, is exercise tolerance testing is used for patients with chronic pulmonary disease. Interestingly enough, exercise tolerance testing is also used for other things. There's a concussion test that you do that's called the Buffalo Concussion Treadmill Test. I just did it in the clinic the other day. It's cool. You're measuring different things though. So exercise tolerance testing is similar, but you're measuring different things. Radiography, of course, you're going to look at tumors, you're going to evaluate infections. Bronchoscopy, they put a scope into your bronchi to perform a biopsy or to check the site of lesion or bleeding. So usually when they put a scope in, they can see what's going on in there. Culture and sensitivity tests, just like any, when you're doing testing for infection, a lot of times with your respiratory stuff, you're testing sputum for presence of pathogens and determining the antimicrobial sensitivity of the pathogen that you find. So there comes a time in the course of every pathophysiology class where we have to talk about sputum, and in the digestive system, we're going to get to vomiting. So it happens. We're going to have to talk about it. And one of the things that that's very of interest for diagnosis is the color of sputum. So we'll talk about it. Breathing patterns and characteristics. Anything with PNEA is breathing. So we've talked about dyspnea and orthopnea. Eupnea is the normal rate of breathing. 16 to 20 respirations per minute in and out. Kussmaul respirations are deep, rapid respirations. They're typical for acidosis, but they also may follow strenuous exercise. So Kussmaul respirations are not necessarily abnormal. We're just trying to restore our balance. Labored respiration or prolonged inspiration or expiration is often associated with obstruction of the airways. Wheezing or whistling sounds may indicate obstruction in small airways. Stridor is a high-pitched crowing noise, and it usually indicates an upper airway obstruction. Sometimes with croup, which is an infection that sometimes babies will get, or little kids, you get stridor, that high-pitched crowing noise. So these are respiratory patterns. This chart is from the book. Just like tachycardia and bradycardia, you have tachypnea and bradypnea. Tachypnea is rapid superficial breathing with a regular or irregular rhythm. That's different from tachycardia, which has a regular rhythm. Bradypnea is slower respiratory rate, deeper than usual, but it has a regular rhythm. Apnea is cessation of breathing. So I'm sure a lot of us have heard of sleep apnea. It's where you stop breathing when you're sleeping. So apnea is cessation of breathing. Hyperpnea is an increased depth of respiration with a normal to increased rate and a regular rhythm. So hyperpnea is increased depth of respiration. Kane-Stokes respiration is periodic breathing associated with periods of apnea. So it alternates with a series of respiratory cycles, and then the respiratory cycle gradually increasing and then decreases in rates and depth. Kane-Stokes respiration is often goes on like towards the end of life. So you start to get these recognizable breathing patterns. Ataxic breathing pattern. So you can, when you see the word ataxia or ataxic, it usually means discoordinated in some way. So there's something going on that there's some discord. So you can have ataxic motion and ataxic speech. Ataxic breathing is periods of apnea alternating irregularly with a series of shallow breaths of equal depth. So it's like uncoordinated breathing. You can think of it that way. Small, we talked about regular sighing respiration with an increase in respiratory rate. It could be caused by something as simple as strenuous exercise. Apneusis is long gasping inspiratory phase followed by a short inadequate expiratory phase. So you tend to store extra air in your lungs. You're breathing in more than you're breathing out. Obstructed breathing is long, ineffective expiratory phase with shallow, increased respirations. So breathing obstructions, obviously, that's a 911 situation. And we've all done the training in CPR training for obstructed airways. So this is a list of basic therapies for respiratory disorders. So no matter what the disorder, we are going to probably, just like with cardiovascular disorders, there's sort of basic therapies, same with respiratory disorders. So avoiding inhaling irritants and maintaining good ventilation. So like don't smoke and don't be around industrial pollutants, basically, to reduce inflammation and infection in the respiratory system. Current immunizations to prevent infection, humidifying the air to keep the mucosa moist. Moderate exercise, that's a great idea. We should do that to improve lung function and circulation. Breathing and coughing. So sometimes we'll do, and you'll learn this in your what do I want to call it? Neuro rehab class, assisted breathing techniques and that sort of thing. And we will also have a section this summer with chest physiotherapy to remove thick secretions and reduce infections. Postural drainage and clapping. Generally, if you work in a large enough area, chest therapy is going to be done by respiratory therapists, but maybe you're a PTA working in small town USA and you might be doing chest therapy. So that is part of what we'll cover in our special topics class. The drugs that are generally basic therapies for respiratory disorders, decongestant to vasoconstrict the nasal mucosa and reduce edema, expectorants to thin respiratory secretions for easier removal, antitussives to reduce the cough reflex, antihistamines to reduce allergic response, analgesics to reduce pain, antimicrobials to kill stuff, that's infecting your respiratory system, bronchodilators to stimulate the beta-2 androgenic receptors to open bronchioles. That's our sympathetic nervous system. And glucocorticoids to be anti-inflammatory and anti-allergenic. Surgically, thoracentesis is removing excess fluid from the pleural cavity to prevent atelectasis, which is collapse of the alveoli. Tracheotomy, which I talked about, incision into the trachea below the larynx to permit air intake when above that is damaged somehow. And surgery to remove stuff. So tumors, abscesses, damaged tissues, etc. So no matter what your respiratory disorder, there are some standard diagnostic tests and basic therapies. Physical therapy, our primary PT goals in the treatments of patients with primary lung pathology Include promoting independence and functional mobility. Sear that phrase into your mind, because when we start to get into some of the other disorders, functional mobility is it in physical therapy. We want to maximize gas exchange by improving ventilation and possibly airway clearance. We want to increase aerobic capacity, respiratory muscle endurance, and the patient's knowledge of his or her condition, so they can continue to exercise and continue to have good functional mobility. The general interventions that we do in PT to accomplish these goals are breathing retraining exercises, and that you're doing that a lot. That is part of our patient education, is breathing retraining exercises. Secretion clearance techniques, if your friendly hometown respiratory therapist is not doing those. Positioning, that's important. That's really important. Functional activity and exercise with vital sign monitoring, that we've been doing that all quarter, right? And patient education, very, very, very important. That is one of the most important interventions that we do in all areas of physical therapy, is patient education.